Logo, BAME Vision. So welcome to today's session on diabetes management, preventing and looking out for signs for diabetic retinopathy. We'll be discussing what is retinopathy, diabetic retinopathy. So welcome today. It is World Diabetes Day today, and therefore we're hosting the workshop through BAME Vision. Today, my name is Bhavini Makwana. I'm the chair of BAME Vision, and I do have one of my colleagues with me today who will be speaking, Adam Mapani, who also chairs the BAME Vision committee alongside me. Today, we really wanted to talk about, diabetes because it is quite prevalent in BAME communities. And sometimes we don't always get the information that we need in an accessible format, in a language that best suits us, or even when we visit our healthcare appointments, time is of the essence. So today really is to get that piece of information, and because it's prevalent amongst BAME communities, we really wanted to highlight the importance of good diabetes care and management. So our speakers today will be discussing more about that, as well as informing about other complications that could arise. We always hear about feet, kidneys and other parts of our organs, but not so much about our eyes. Diabetes can affect our eyes, our vision, and if you do lose your sight due to having uncontrolled diabetes, it's a condition called diabetic retinopathy, and it's a condition that's actually quite high amongst working age people who have diabetes. So it's quite an important eye condition to be aware of, and the signs of it. And through good diet and nutrition and good care and management of your diabetes, we can hopefully try and save your sight and prevent it from being lost. We'll also have Tony Kelly, who will be speaking from a personal lived experience of having the condition and how he's managed to well, I won't say no more, how he's managed to, have good care, good, advice and information where he's been able to take control. I'm really looking forward to hearing him speak. So we'll be hearing from Razia Amin, who is a nurse consultant specializing amongst diabetes, and also Adam Mapani. Like I mentioned, we will have a Q&A session for you to ask your questions. And so I hope you find today useful, beneficial. And like I said, this is being recorded, so there is option to watch it back. And I'd like to hand over to Razia Amin, who will be our first speaker for today. Please do introduce yourself.
Hi, hello everyone. My name is Razia Amin. I'm a diabetes nurse consultant. I work with Northwest London CCG, and thank you so much for inviting me to speak here today. It's really lovely to be here with you all. So on to the next slide. What I'd like to speak about and discuss in this session is briefly what diabetes is, just in case anybody who's joined us isn't really aware of what diabetes is. What causes diabetes? Diabetes management, particularly around reversing diabetes and healthier eating. So hopefully this will cover the main areas that people actually wanted to know more about. So what is diabetes? Well, when we eat anything containing sugar or starch, starch is also known as carbohydrate, and when it enters the stomach, the carbohydrate is broken down into glucose. So the glucose enters our bloodstream, and the pancreas, which actually plays a part in utilizing the glucose in our body. So the pancreas either doesn't release insulin, or the body is resistant to the insulin that is needed to allow the glucose to be converted into energy. So what happens is the glucose actually builds up in the bloodstream, and that's what causes diabetes. So diabetes is when the glucose level in the blood is too high. Now, when the blood glucose is too high, some people have symptoms, and these are things like going to the toilet frequently to pass urine, feeling thirsty, feeling tired, having blurred vision, having cuts and sores that maybe are slow to heal. Sometimes people have infections such as thrush. Also, just to say that not everybody experiences symptoms. So many people can have diabetes for a long time before it's diagnosed. So there are two types of diabetes. There's type 1 and type 2. Type 1 diabetes can't be prevented or cured, and the body stops producing insulin and people need insulin injections for life. Type 2 diabetes is the most common type of diabetes, and around 90% of the people who have diabetes actually have type 2 diabetes. So that will be the main focus of our discussion today. So for many people with type 2 diabetes, it can be prevented through lifestyle modification. So this slide actually shows the factors that increase the risk of developing diabetes. So some of these are family history and genetics. And just to make you aware that some ethnic minority groups are at much higher risk of developing type 2 diabetes, particularly those from the South Asian communities and people from China. We're more likely to get diabetes as we age, and we get older, and also if we're inactive or we're overweight. Also, some other conditions, such as having severe mental illness, some medications, such as steroids, they will increase the risk of developing diabetes. So what actually causes type 2 diabetes? So what happens in the body? And I wanted to explain this. One of the main issues is having excess body fat, and the amount of fat that you can store before it starts becoming a problem will vary from person to person. So for all of us, we can store a certain amount of fat under our skin, but when we have too much fat, it goes into other places in the body. And two of the organs that it will go into are the liver and the pancreas. So people with diabetes can end up having a fatty liver and also having fat in the pancreas. And when this fat gets into the pancreas, it stops the insulin from working properly, or it stops it being produced. And this is what, in many cases, causes type 2 diabetes. Not in every case, but in many cases. So I want to speak a little bit about body mass index, and what, excuse me, body mass index compares weight to height. So on the screen here, you'll see a picture. So it's two people of the same height, but they are of different weights. So the lady on the left-hand side, you can see that she is of a lower weight than the person on the right-hand side. So, the person on the left-hand side probably has a normal body mass index, and the person on the right-hand side will have a high body mass index. So that is what body mass index is. And a healthy body mass index for people is below 25. Now, again, for people from like a South Asian minority groups and people from China, a healthy body mass index for them is 23, because they have lower thresholds for getting diabetes, and they're at higher risk at a lower level. So they would be classed as overweight if their body mass index is above 23. Okay, and so that's an important thing to remember in terms of different communities and developing diabetes. Now, diabetes can cause major complications. So if the blood glucose levels are high, it's not just about blood glucose levels. So if the blood glucose and the cholesterol levels and the blood pressure are high, that can affect the blood vessels, and they affect the blood vessels from our head to our toes, and they increase the risk of developing diabetes complications. Now, microvascular complications on the left-hand side affect the small blood vessels and can lead to dementia, damage to the eyes, kidneys, and nerves. And Adam is going to speak about the diabetic retinopathy, which is damage to the eyes later on in the session. And the macrovascular complications are damage to the big blood vessels that can lead to people having strokes, heart disease, and peripheral vascular disease. Now, it's not all bad news, because we know that if the blood glucose and the blood pressure and the cholesterol can be well managed, then people really reduce the risk of having these complications. And in this picture, I just wanted to show you an example of neuropathy, which is damage to the nerves in the feet. This was somebody who attended a podiatry appointment, in one of the hospitals that I used to work with. And when they attended, they didn't know that they had a piece of broken glass stuck to their feet. And because the nerves had been damaged, they didn't feel that they had been walking on that all the way to their clinic appointment. So luckily, in this case, the glass hadn't actually damaged the skin or broken the skin and caused a sore. So looking at diabetes management, I mean, our bodies are amazing and we do take them for granted some of the time. And looking after our bodies makes a real difference to preventing the complications of type 2 diabetes. And what we do will have the most impact on our diabetes and our lives. Key messages about diabetes management nowadays are really about prevention. So it's about prevention, prevention, prevention. And when diabetes does develop, it's about eating healthily, being more active. And both of these should help people to lose weight and improve their blood glucose levels. Some people will go on to require medication or insulin in the future. But, making the lifestyle changes is one of the key parts of diabetes management and diabetes treatment. Other important lifestyle changes that are really important to try and change are stopping smoking, which also increases the risk of developing complications, and not drinking alcohol excessively. So in this slide, I just want to explain what HbA1c levels mean. And HbA1c is one of the main measurements that's used to diagnose diabetes. So it measures the average blood glucose, and blood glucose is another name for sugar, but we call it blood glucose just so that there's no confusion. So it measures the average blood glucose over the previous 3 months. Now, the normal blood glucose, and that is when people don't have diabetes, is having an HbA1c under 42. And diabetes develops when an HbA1c is 48 or above. And in between, when the HbA1c is between 42 and 47, that is, it's got different names. Some people call it pre-diabetes. Sometimes it's known as non-diabetic hyperglycemia. But it means that people in this range are at really high risk of developing diabetes. And there's lots of things that they can do to reduce the risk of actually getting diabetes. There's lots of advice and information available, and there's programs available nationally. One is called the Diabetes Prevention Program to help people to, avoid getting diabetes. So this is an important thing, and I wanted to actually discuss about whether type 2 diabetes can be reversed. And, you know, this is an important point because at one point we just thought diabetes was a progressive disease, and over time it just got worse and people needed more and more medication, and then some people eventually would need insulin. Now that is the case for some people, but for many people, diabetes actually can be reversed. We don't call it being cured because it's to do with weight loss. And if the weight actually is put back on, then the diabetes can come back. But we know from lots of studies and lots of research that's been done recently that if people are really overweight and they lose about 10 to 15 kilos, it gives them a really high chance of losing the fat in the pancreas and reversing the diabetes. So we call that getting into remission. Now, losing about 15 kilos gives you about 90% chance of achieving remission, which is huge. Remission means that your blood glucose levels are healthy without needing to take any diabetes medication. You know, and it's important to also know that not everybody gets their diabetes into remission, but even with losing some weight, say for example 5 kilos, that will reduce the risk of heart disease, cancer and arthritis, as well as helping people to improve their sleep and energy levels. So if weight loss is so important, how can we lose weight? So just to take you through this slide here, I mean, the main and the key thing is insulin. So when we have high carbohydrate diets, we know that the blood glucose levels rise and the insulin levels rise. The insulin helps the glucose that's in the bloodstream to be stored as fat, and the fat burning is switched off. The cells in the body become resistant to the insulin, and you know, people, because they're not getting the energy from the food they're eating, it's just the glucose is staying in their blood and not getting into their cells and their muscles and that to give them energy. They just keep craving for you know, eating things, and they, you know, they feel hungry and things. So they're in this vicious cycle of storing fat and you know, not losing weight, and it has an impact on the diabetes. So then we look at how can we increase fat burning. So to burn fat, we actually need to reduce the amount of carbohydrate we eat quite significantly. And there are several programs available nationwide. In Northwest London, where I work, we have a program called Rewind, and it has two options. One is a low-calorie soups and shakes option, where people just have soups and shakes for 3 months and then gradually reintroduce food back into their diet. And it's a year-long program. People get support over that time. Or there is another option of having a low-carb diet. And as well as that, there is another way that people can increase fat burning, and that is with intermittent fasting. So just to go back to the low carb diet, you know, I mentioned that it was just a really low carbohydrate, low calorie diet. It's just about 800 calories a day. It's very strict, very severe. The low carb diet is where people reduce sugar, things like fruit juice and like starchy foods such as bread, rice, pasta, noodles, potatoes, you know, all these sort of starchy foods. It could be yam, cassava, plantain, you know, all these sort of foods. And the intermittent fasting, that works because you're limiting your eating to 8 hours a day, and you tend to miss a meal, and you tend not to snack so much. So then that starts the fat burning. Okay. So all these things will help the insulin levels to drop. Now, I just want to say as well, like, I'm just giving you this today for information. So, you know, we wouldn't want you to just go ahead and do one of these things. They should be carried out under strict medical supervision. So if you want to consider any of these options, discuss them with your diabetes teams, because there might be programs available where you are that you could join. And the reason it's really important is to keep you safe, because if you do make drastic changes to your diet, you know, it would probably need some adjustment or reduction of your diabetes medications to keep you safe. So really just wanted to make that really important point. Okay. So the other thing that's really important is obviously physical activity, and that can be any activity, any regular activity is beneficial for our health. It can help us to lose weight, improve blood glucose levels, improve well-being and mental health. And it helps to keep our muscles and bones strong and reduces the risk of cardiovascular disease. So we would just recommend that people do anything that they enjoy. So that could be walking or cycling or swimming or dancing, things like gardening or housework, washing the car. All these things count, you know, so physical activity is also a really important part of diabetes management. So now I want to come on a bit more to the food aspect, because I know a lot of people are, you know, really want to know about food and what foods they should have, or, you know, what portion sizes they should have and how food affects their glucose levels. So on this slide here, I just want to show you that when carbohydrate is eaten, and an example given here is a banana, it's broken down into carbs, it's broken down into glucose, and the glucose enters the bloodstream. So depending how much glucose is in the food that we eat, you know, that will affect the blood glucose. The second thing there is the naan bread. So if somebody has a naan bread, the carbs are broken down into glucose, and the banana had 17 grams of carbs. The naan bread, this size, this portion here, had 43 grams of carbs. So you can see that there's a lot more sugar in the naan bread. So you get more sugar that enters the bloodstream. So the amount of carbs we eat has a huge effect on our blood sugar levels. I just want to explain very briefly that my colleague, Dr. Jones St. John, has written a book called World Foods, Carbs and Cals, along with a dietitian called Salma Mehar. And most of the pictures that are in this section are from this book. So it's a really useful book to have. So the portions of carbohydrate are shown in sugar cubes, and each sugar cube is equivalent of 1 teaspoon of sugar. Okay, so it really helps to understand portion sizes and the effect they have on our blood glucose. I'm aware I'm just running a bit slow, so I'm just going to speed up here just so I can let everybody have their allocated time for speaking as well. So this is an example with rice. So you can see the small portion there, 10 grams, the medium portion there, which is 51 grams, and the large portion there, which is 91 grams of carbohydrate. So you can see when they're digested, the sugar gets into the bloodstream. But I don't know, we're often not aware just how much carbs and how much glucose it turns into with the portion sizes that we eat. So you can see with the bottom one, with the large portion of rice, that 91 grams of carbs is turned into 18 teaspoons of sugar. Now, you would never think that when you're sitting eating a plate of rice, that is how much sugar that you're eating. So I really just wanted to use this to make you aware. Just often we don't know what how much carbohydrate and how much sugar we're eating. And you can see there as well, with a small portion of carbs, the effect on the blood glucose is small, like the blood glucose might go up a little bit, but it comes back down. With the medium portion of rice, the effect on the blood glucose level is much more. The sugar level goes up much higher. And at the bottom, you can see on the right-hand side, the effect of having the big portion of rice. You can see that huge spike in the sugar level in the blood. So I know that people wanted to know a little bit about different meals that you might have. So these are examples of African meals. So on the left-hand side, there's chicken stew, pap, and greens. And again, you can see with the different portion sizes, you can see just how much glucose is going into the bloodstream from digesting the portion sizes that are there. On the right-hand side, there's chicken stew and rice. And you can see the smaller the portion of the carbohydrate, the less effect it has on the blood glucose levels. For Caribbean meals, this is on the left-hand side, curried goat with rice and peas. And on the right-hand side, there's fish, banana, yam, and dumpling. And again, it just shows how much sugar can be in some of these bigger portions of carbs that we eat. South Asian meals often consist of like things like chapatis and that. And again, like that is 180 grams of chapatis at the bottom. And that has 180 grams of carbohydrate, and that turns into a lot of glucose. So thinking about meal swaps, so on the left-hand side, that fish dumpling, green banana, yam, and coleslaw, the amount of carbohydrate that has is 204 grams. And you know, the equivalent to that in teaspoons of sugar is 41. So that is a huge amount. So that is coming from 260 grams of dumplings, 100 grams of green banana, 140 grams of yam. And to reduce all that glucose, it's a matter of changing maybe the type of carbs we eat and the portion sizes. So if that is changed to fish with rice and peas and the sort of portion size that is on that plate, and with lots of greens, you're reducing the sugar to just 7 teaspoons of sugar. So what a big difference that can make, you know, just changing what we eat and the portion sizes of what we eat. An equivalent South Asian meal swap there is chicken curry and rice. So if we change what's on the left-hand side to what's on the right-hand side, so having just a bit less curry, saying that chicken and protein foods don't tend to affect the blood glucose levels, it's mainly the carbohydrate. So by reducing the carbohydrate and the portion of rice, that will reduce the amount of sugar that goes into our bloodstream. And that will help us to, you know, manage our blood glucose levels and also manage our weight, and maybe even help us to get rid of, you know, get the diabetes in remission. And, you know, when we're reducing foods, like reducing portion sizes of things like rice, we want people not to feel hungry constantly. So it's about replacing them with other foods which won't affect the blood glucose levels and will help fill you up. So in this case, there's salad there. So I hope that gives an idea of how our diets can be changed. And on this slide here, you can look at like portions of healthy plates, and on all of them, you can see that there's lots of salad and green vegetable to replace, you know, the bigger portion sizes of carbohydrate, while you're still eating your protein foods like your fish, your chicken, your pulses and grains and things. this slide here just shows you some fruits with the lowest carbs, like things like berries and that, and the vegetables with the lower carbs. So anything really that grows above the ground and green, things that are green tend to have less carbs. Foods that are grown like under the soil, so things like parsnips, carrots and things, though they're vegetables, they will have some carbs, but they're still very healthy. And just a summary of the dietary advice then is really just to overall eat more good fats, including olive oil, oily fish, avocados, nuts and seeds, more beans, pulses, green vegetables, and to reduce the carbohydrates. So that is all the things we mentioned earlier, the rice, the bread, the potatoes, the pasta, the chapatis, the yam, the cassava, the plantain, and also reduce the bad fats, which are trans and saturated fats, which are found in biscuits, cakes, and these sort of foods. And also remember to have well-managed diabetes, to become more active and quit smoking. Now, these are the things that I wanted to cover. I'm sorry I've run over time. I just want to say thank you very much. And there is one question I haven't answered, but hopefully I'll answer it at the end when we get the questions. Okay, thank you.
Thank you, Razia. That was very informative and very useful, and I'm sure people would have found that very interesting and fascinating. I would like to hand over to our lived experience patient speaker, Tony Kelly, and feel free to screen share and introduce yourself, Tony. Welcome.
Thank you very much. I've started sharing my screen and I went, right. So, hello everybody. I have to thank Adam and Razia for putting on this event on World Diabetes Day, with a specific emphasis on the eye. We're talking about eye care in particular, which is the Cinderella of all the conditions that people with diabetes suffer from. So my name is Tony Kelly. I'm based in Birmingham. I'm a diabetes strategic patient partner for Birmingham and Solihull Clinical Commissioning Group. And those who are listening, especially from abroad, because I see people here from Jamaica listening in, welcome. The CCG, or Clinical Commissioning Groups, after March next year, will no longer exist. They're going to be called Integrated Care Systems, ICS, instead of CCGs. So that's something we all have to get used to, that yet another acronym. But as I said, I'm based in Birmingham, and here goes. I am not a healthcare professional. As Razia rightly said at the beginning, I'm not a dietitian, I'm not a healthcare doctor or a dietitian or any of those things. But I've had this medical condition, diabetes, this Christmas coming, 18 years. British born, but I grew up in Jamaica. And that's a little cheeky image of me playing a jigsaw puzzle in London. My parents sent me back to the land of their birth, Jamaica, where I grew up in a place called Whitehall, St. Thomas. And as a child growing up in Whitehall, St. Thomas, with my grandmother, granduncle, and grandaunt, I saw the telltale signs starting from the head. I'll just go through them quickly. Strokes, blindness, these are relatives of mine, heart attacks, kidney failure, necessitating they having to go onto the dialysis machine, and the dialysis machines weren't in the country hospitals, they were all in Kingston at the time. Lower limb amputations, which is chopping off of toes and feet. And last but by no means least, premature death. In Jamaica, I'm keeping it real, we say gone too soon. So relatives of mine would be dying at the age in their 40s, 50s, 60s. As a very inquisitive, or would say nosy child, I would ask these relatives of mine, what is the matter with them? They never ever use the word diabetes. All they would say is that they have a touch of sugar. So the Caribbean, Asia, and Africa tend to refer to diabetes as a touch of sugar. So they minimize or trivialize or downplay this medical condition. I know some people call it an NCD, non-communicable disease, or an acute disease. In all of my training, I was told to call it a medical condition. So I've stuck to that. So they had this, and of course they're dying and chopping off of limbs and so on and going blind and so on. I went to micro teachers training college and taught in the high schools in Jamaica, then decided to come back to Britain in 1979. So I've been back in Britain here now 42 years, going about my merry life, because I used to do track and field at the National Stadium for high school and for micro teachers college and youth club, skinny as a rake. But I'm in England now, I start to pile on the pounds. But remember, I said diabetes runs in my family. It's hereditary. My wife, 17 years ago, noticed the 4 key symptoms that I might have type 2 diabetes. T for tired, T for toilet, T for thirsty, and T for thinner. So ladies and gentlemen, I was getting up 2-3 times during the night to go to the toilet. She kept saying, something's wrong with you, something's wrong with you. But most men, and this is a fact, most men are in denial. Most men are not in touch with their feelings, not in touch with their emotions. Most men don't do doctors. And you women on the program need to go and encourage your men folk to go and get their health checks yearly. Here in Britain, we have to get our car MOT tested once a year to make sure it's roadworthy. I am saying to you listening here, your body given to you by Jah, Jehovah, Allah, Muhammad the Prophet, or whoever you worship, is a far more important thing, your body, your temple, than a motor car. So it's about getting your health checks done. So Diabetes UK asked me to come and speak in Wolverhampton, which at the time was the diabetes capital of Britain, 9 years ago. And then I spoke for 10 minutes about how I manage mine without any medication. And they said, come over to Macedonia and help us, meaning, hey, you've got the gift of the gab, you can chat, you'll be able to get out there to African, Caribbean, Asian communities. So I've been doing it now 9.5 years, going into communities, and I must big up my family. The National Health Service was formed in 1948, for those who are not aware of it. The Second World War was 1939 to 1945. Britain sent over people to Asia, Africa, and the Caribbean to recruit people to come and train as nurses. In the middle, my aunt came in 1952. On the left-hand side in 1953, my mother came to be trained as a nurse in London, followed by their other sister in 1956. So 3 sisters from one family came here to study nursing. So I take strong objections to when I see NHS literature and so on and photographs showing just white people having built up the NHS. Here is a prime example of 3 nurses from one family in Bath, St. Thomas, Jamaica. They made their contribution to the NHS. So this is why we need to change the narrative in that regard. I hear a lot about hard to reach communities. I hate, I loathe, I detest the term because I go to a lot of events, as you can appreciate. And when I ask, who are they referring to? You hear the consultants and the doctors and the researchers and the clinicians talking about hard to reach communities. They are referring, and if you look it up on Google, you'll see about 16 to 17 pages of hard to reach communities. They are referring to African, Caribbean, and Asian people. I ask you people, challenge it when you hear it. We need to change the narrative. Are these people on Mars, Jupiter, in the Himalayas, in the ocean, in the jungle, on Mount Everest? We make up the community. And if I can go and do 150 community events since I retired as a middle manager in equality, diversity, inclusion, if I can do 150 community events, I am saying to the healthcare professionals, whatever bodies they work in, they need to get from behind their laptop, they need to get from outside their ivory tower, their desk, and go and engage with the communities, because that's what I do. I go and knock on gurdwaras, temples, mosques, churches, residential homes. No community is hard to reach. The next slide tells you that you must say instead, historically excluded. These are the words you must use. Challenge it. Historically excluded, historically neglected, historically ignored, marginalized, or underserved are far more appropriate terms to use. And if Muhammad can't go to the mountain, then the mountain must go to Muhammad. So be proactive. And the whole idea is about doing more diet and physical activity. I do a lot of work with people who have blind and deaf, so hearing impaired and sight impaired. and they don't get a look in. When I go to those events for the sight and hearing impaired, they ask 1,000,001 questions. I can't leave. And I will say to the signed interpreter, why are they asking so many questions? And she says, Tony, or he will say, Tony, nobody involves, and there are a forgotten lot of people. It's as if they're not human beings, as if they're not existing. And I'm saying, just like how Razia and Adam, who work in particular with people with sight impairment and so on, we need to go out and reach to these people and engage them on the health and well-being agenda. So don't give me this issue of hard to reach. The same with white working class people. I go where they are, and I'm saying to people here on this webinar, it's not health clinics, medical centers, and hospitals you need to go to. Go to the rum bar, go to the pub, go to the club, go to the hairdressers, go to the car boot sale, where you know, go to the football match, where you know crowds will gather. That's where you must go and engage with people. You'll notice I have on my top, I have a few of these, and 30,000 feet in the air, or on the train going to London, or in the Bullring shopping center, or the markets in town, or the supermarket, people stop me. Excuse me, your badge says diabetes. And I just have my cards ready to hand out. That's how I get engagements. That's how I think outside of the box. Moving swiftly on, because of time. That just shows a graph of Birmingham and shows where diabetes is prevalent. And I don't like the words inner city, but that's what they're referring to. Some of the inner city areas, you'll notice the diabetes rampant. It's more prevalent there, like Aston and Nechells and Handsworth and Lozells. And the reason for that is the fast food or takeaway shops, what I refer to as junk food. I am saying to people in those communities, go and learn to cook. Full stop. Now, whatever the fast food Monday to Friday, the junk food or whatever, you need to bypass it and go home and prepare the food so you know what you're putting in it, how much salt you're putting in it, how much sugar you're putting in it, if at all any. So that's my answer to that in terms of diet. So those are the places which I won't dwell on that I go to, the barber shop, the hairdressers, the church, the mosque, all those places. You'll get this when you look at this later, where you can go and find people, the Rotary Club, the Kiwanis Club, the Lions Club, etc. This video I won't show, but I'll tell you where it is. It is a 2-minute video on the Diabetes UK website. It's only 2 minutes long, and it says, what is diabetes? You need to go show your children, your grandchildren, your neighbors, your relatives, your friends, that 2-minute video. It encapsulates exactly what diabetes is. I know Razia did touch on it at the start and so on, but that also encapsulates it quite well. We won't have time to watch it now. At the moment in Britain, I can't speak for anywhere else, some people are not being able to see their doctor, keep appointments, or can't get their bloods done because we have a shortage of the vials. Please go to the Diabetes UK website, where over 1 million people have gone. There is a Know Your Risk tool there. You put in your height, you put in your age, you put in your gender, you put in your waist circumference, you put in your ethnicity. It can work out for you from that Know Your Risk tool, whether you're no risk, low risk, LOW risk, medium risk, or high risk. And if you're in the medium or high risk, and this means you haven't got diabetes yet, it can signpost you, because you put in your zip code or your postcode, it can signpost you to one of the national diabetes prevention programs run all over the country, courtesy of the NHS. They have people who run these programs for you to go on. These are people who don't have the condition yet. So in order for you, prevention is better than cure, to help you to not get the condition. So eating a healthy, balanced diet, be more active. And if you're a smoker, I urge you to give up. Those are some of the things that I do: print cards, badges, all that sort of thing, phone calls, text messages, and I badger people. I don't take no for an answer. Those who will know me from my days at Micah and my days in Jamaica and so on know that I don't give up. And those are how I get engagements with communities. So I'm not subscribing to the hard to reach agenda. So some facts, cultural myths that are out there. These are cultural myths which we talk about, and I talk about when I do my training with slides. Diabetes is a mild condition. It's a touch of sugar. We have to park that one. It is God's will or Allah's will that you're going to get it. The Bible or Quran say you're going to get it, so just accept it. That's another myth we have to dispel. If one is fasting during Ramadan, and a lot of people are in Britain and abroad are Muslims and Islamic and fast, if you prick your blood, prick your finger during the blood and just test your blood, you broke your fast. Absolute rubbish. Being big is beautiful. There are some communities where you'll see the man, he's as meager as ever, skinny as ever. Next walking beside him is his duchess, his queen, his conqueror, his beauty, whatever, beauty queen, princess. And she's 6-7 times his size. And some communities, they actually spend their time, the man does, bigging up the woman so she has bigger breasts and bigger bottom and a whole bigger outlook. Less is more. Big is not beautiful. There's this thing about only people who are overweight, with all this weight around the tummy area, who can get diabetes. People who are obese, mildly obese, or morbidly obese. People who have fat on the inside, it's called 40. So you sometimes come across, not many, but thin, or in Jamaica where there's a mager people, who are fat on the inside. So they're very skinny, but the pancreas, which is just a 6-inch gland behind the tummy area, the fat is actually building up around the pancreas and around the liver, causing them to get diabetes. And people marvel and say, well, how can they have diabetes and they're so skinny? That's because that's happening to them. Some believe if you cut down on all the sugars, as my colleague before said, you'll be fine. But you need to understand every single carbohydrate you eat breaks down into your body into glucose or sugar. And coming back to the eyes, I see so many people in their 50s, 60s, 70s who start squinting and not seeing the print well and so on and having blurred vision. And they think it's because they're getting old. Ladies and gentlemen, trust me, it's the diabetes having its wicked way at the back of your eyes, causing you to have blurred vision and to eventually go blind. There are 4 countries in the Commonwealth where diabetes and blurred vision and blindness is rampant. Dominica, Jamaica, St. Lucia, and Belize. I was in Dominica a few years ago doing this same sort of awareness raising. I'm also going to be doing it in Jamaica hopefully next year. You need to go. So many people said to me, Tony, when I went to my optician, the optician noticed something at the back of the eyes and said, oh, you need to go and see your GP and your doctor, that is, and get a blood test. So you need to, opticians need to be in this game. They seem to have been left out of the equation. And that is sad because they are at the cutting edge of seeing so many people who have to go for their eye checkups each year. I have to every year, and they put drops in my eyes. Adam will talk more about that because he's a nurse consultant in that regard. And they send it off and they say, Tony, you're good to go. Your eyes are perfect. There's nothing wrong with your eyes. But if you notice the blurred vision, go get it checked out. Some of the do's, don't use the word exercise. It's not a word that I use in my 9.5 years. Used to, but stop. Say physical activity. Those are all the things that I do that you see there. Linford Christie learned to swim just before lockdown. And I saw that in a newspaper article the other day. And I thought to myself, Linford Christie, the great runner from Britain, if it's good enough for him, it's good enough for me. So I know I've just had my 4th swimming lesson. I'm a non-swimmer, I couldn't swim. But I'm determined that in my 60s to learn to swim. Pick up a hobby, with fast-paced walking, washing the car, climbing the stairs, etc. Pro-social modeling, lead by example. I take the winter flu jab every year. I've had it for the last 18 years. It's never done me any harm. I also have the COVID-19 jabs, and I've also had the booster. And every 3 months, I am a blood donor. More African, Caribbean, and Asian people need to donate blood. When I go to the blood bank in New Street, Birmingham, I see very few African, Caribbean, Asian people there. I am saying to you, you have relatives who might need blood. You need to start thinking, hey, I'm going to take Tony's example. Every 3 months, men give blood. For women, it's every 4 months. 4 months, beg your pardon. Speak the language of the people. I hate jargon. I hate medical terms, and I hate acronyms. When I'm out there in communities doing events, I keep it simple. I keep it real. I want people to understand what I'm saying. So there's no hot potato in my mouth, and there's no speaking a language where it's showing that I went to Oxford and Cambridge. That doesn't work in communities. I'm not saying you must be patronizing and condescending, but you must speak the language of the people. Conscious of time, observe body language when you're out there, especially you who are professionals. If you notice the person is not engaging with you or not taking the leaflet or not really, or the body language, it might be a case of they are unable to read or write. You must bear that in mind. There are people, not just Asian people, African, Caribbean, white, working class people who are unable to read or write. Pick up the body language and the signs and try and engage with them a different way. I hear that so often when I do events out there. When I say, right, we're going to do the quiz now. The person says, oh, I forgot my reading glasses. They haven't forgotten any reading glasses. They are unable to read or write. You must pick up these signs and symbols and sort of cues. So the 4Ts I've mentioned, but sometimes there are no symptoms whatsoever, which is why I'm saying you must go yearly and get your health checks done, just like how you get your car or your vehicle MOT tested. So the strokes, the blindness, the heart attacks, the lower limb amputations. Black people are 2 to 4 times more likely than white people to develop diabetes. And wait for it, we start developing it at age 25. White people on the whole start developing it at age 40. We need to get rid of this couch potato sedentary lifestyle, and it's also to do with our DNA or our genetics or metabolism. It is different from white people, which is why we get it earlier. And notice these careers who get diabetes earlier, whether black or white. Train drivers, tube drivers, lorry drivers, bus drivers, taxi drivers, simply because they're sitting on their proverbial, on their backside for most of the day, and they're not doing any physical activity. So you have to encourage them when they get home, instead of sleeping in front of the television, walk around the block, climb the stairs, do some line dancing, do some Zumba, what have you. This November is 100 years since Sir Frederick Banting, a Canadian scientist, with his French medical student, discovered synthetic or artificial insulin, which all type 1 people have to inject, because you can live without an eye, an arm, a leg, or tooth, or your feet. You cannot live without insulin. So all type 1 have to take insulin. That's 10% of people with type 1. 90% of people have type 2. Some survive, as was said earlier, on diet only and physical activity. Some have to take insulin. Some have to take other drugs, such as metformin. And we give God thanks and praise for when that was discovered. It's been made better since and been improved on. That's just showing you gender differences. Most women are well versed in going and seeking help at the health clinic, the doctor, or so on. Men are the complete opposite. I'm telling you to encourage your men. It's the same with things like prostate cancer. They suffer in silence, bury their head in the sand instead of going and seek help. That's what I'm about. Don't be like the ostrich. Because if, for instance, prostate cancer, I digress a bit, is caught early, it's one of the easiest cancers to cure. The same issue with diabetes. Encouragement to seek help. Because I, as you know, didn't seek any help. When I finally did, look at me now. I haven't stopped. I haven't stopped talking. I go on and on. Those are the sort of comorbidities that COVID-19 brings about. But apart from that, we must never lose sight, and it's in red, of the systemic structural racism, health and racial disparities and inequalities that exist within Britain. We need to bear those in mind as well. COVID-19 has clearly brought that home to us. I won't bother to go through my personal experiences as such. I've mentioned I give blood. I also very quickly will say I have the sickle cell trait, not the full-blown sickle cell anemia or the sickle cell disease, just the trait. So I have to have what is called a fructosamine test, which only allows the doctors and the clinics and the hospital to know what I've ate or drank in the last 2 weeks, not the last 3 months, which is what the HbA1c would normally do. So more black people have the sickle cell trait, sickle cell anemia, thalassemia is another one. So you need to be mindful when you go to give your bloods on that score. I must mention the National Health Service result letter, which comes every year to me. This is what's on it. Manage your blood. Make sure your blood is monitored. Go for regular diabetes checks and continue to attend your regular diabetic eye screening. I'm in a ding-dong battle for the last 4 years, and I'm not giving up with the powers that be in the National Health Service, because I'm saying on that result letter, please put do physical activity and eat well. Just 2 simple things. If you put those on there, it might resonate with people. And I'm going to get that change. Believe you me. Okay? So make perseverance your motto. Be patient. Show empathy, not sympathy. People might relapse along the way. Yes, that's if it's a fair selection. Everybody climb the tree. The only person who can climb the tree might be the monkey. The bird might be able to fly up. But go for equity, equality, and liberation. Equality is when you put everybody on the same level, and they're looking at the baseball or the hockey or the football match. Equity is when you put the little boy or the little girl at the end on 2 stools, so he or she is able to see the game. The tall guy doesn't need it. But what we need to do is complete liberation. Remove the barriers, remove them all together. So you have no barriers, no obstacles, no hurdles in there. Everybody just stand up there and watch the game. And that's what we need to do in the National Health Service. Thank you very much.
Thank you, Tony. That was amazing. Very, very passionate and energetic, and it certainly shines through. I'd now like to hand over to Adam Mapani, nurse consultant at Moorfields Eye Hospital.
Thank you, Bhavini. Good afternoon, everyone. And it's my great privilege and honor to be part of the discussion panel. And it's even more challenging for me to speak after great speakers sharing their practical expert experience. And I would want to reassure all the guests on this platform that I will try to stick to time and would like to close this meeting as scheduled 14:25. So I'm still going to try to round up this session by 1:10, trying to kind of like highlight the key points around diabetic eye disease. So my name is Adam Mapani. It's a pleasure to share this platform with great leader Bhavini, who is the chair of the BAME Vision, and also Tony and Razia, my great friends and colleagues. So I will start by probably summing up the extent of the challenge. We are faced with a diabetes tidal wave that is having a global impact on most healthcare systems in the world. Some of you might be aware, but there was an outstanding, well-articulated speech during COP26 by the Prime Minister for Barbados. In your own wise words, she did say that some national problems require global solutions, and diabetes is one of such. So really, we are faced with a challenging public health problems. We're very worrying that we've got 1 million people that are missing that needs to have some form of diagnosis, some form of assistance to get them to be seen and having that form of diagnosis taken good care of. And some of the practical intervention that you've heard from Tony is what everyone's trying to do to reach out to those who may not have been reached so far. 13.6 million people are at risk of developing type 2 diabetes. And by 2035, the numbers are expected to increase. So just to reassure everyone that if you ever come to our services, or for those patients or those who are already in the system, from a Moorfields perspective, we do have a diabetes nurse consultant supporting people living with diabetes coming to our eye clinic. So Razia, that you have heard, is a former diabetes nurse specialist at Moorfields, great colleague of mine. And she has been really instrumental during a time in pioneering these posts. We now have somebody else who is also a great diabetes nurse consultant at Moorfields. So the role of a diabetes nurse specialist in the context of eye department is to try to bring together the whole primary care integration with tertiary care services. So disease education, disease counseling, we take care of the fact that diabetes is a multi-system disease. It affects different parts of the organs of the body as it progresses. And for every opportunity or every encounter with a healthcare professional, this group of people living with diabetes, they need to constantly get those reminders in form of the health education. We also talk about mouth specialists working with local physicians. I think what really COVID has done in the past 18 months is to initiate digital acceleration within the healthcare system. Communication is significantly improved between us and primary caregivers. So the role of a diabetes specialist to ensure that communication goes across to the gatekeepers, the GPs, the screening programs, and also the community at large. Bespoke counseling for new patients and follow-up, those pregnant diabetic mothers coming to see us, or those patients who might have developed microvascular complications before they can be loaded on a course of treatment, they need to see our diabetes specialist. very important for us, we also take recognition of the gaps that are there. I've worked in eyes for the past 18 years. That's like me giving away my age. And I also recognize that some of the insulin, pumps that are out there, some of the exciting development that Razia mentioned, is something that I also need to be kept updated. So knowledge and education is really, really important for those who work in different subspecialties or branches of medicine to keep us updated on what's going on with diabetes care. We also think innovatively about how we can improve the practical experience of those patients coming to us for treatment, which could be either laser treatment, injection treatment, which I'll come into, to just give them that is around, constant reminders, their visual acuity function, the importance of driving, and DVLA regulations and interpretation. So language matters a lot because information given to patients has to be adopted in a way that they can understand. I'm going to try to keep this, slightly medical jargon free. As you know, Tony has been shouting about healthcare professionals using medical jargon. So I'll try to simplify this diagram. So the back of the eye is the retina. It has got blood vessels, and those blood vessels for people with constant high blood pressure and diabetes. So if diabetes is raised, people with diabetes, then there are two kinds of complications that can happen. So these blood vessels that you see at the back, they can either be blocked. A blockage is caused mainly because there's lack of supply of oxygen or blood to keep the retina nutrition under control. So when there's blockage, there's formation of abnormal blood vessels. So formation of abnormal blood vessels is what is described by clinicians in the clinical field of ophthalmology as proliferation of diabetic retinopathy or diabetic eye disease. So you might see this on your appointment letters or for healthcare professionals on the platform, something that is described as proliferative diabetic retinopathy. Then the second complication happens in the macula, which is responsible for central vision. So in this particular case, blood vessels, they leak. When there's leakage of fluid, the retina becomes swollen or edematous. The swollen part of it is described as diabetic macular edema. And this can result in subsequent impact on central vision, being unable to read or drive, but the vision may remain slightly stable over time. But it's important, again, that people, they attend screening. So this diagram shows someone with complications of diabetes in form of microvascular leakage. What we mean by that, because of constant high blood sugars, hyperglycemia, there is an association of those blood vessels in terms of leakage, the yellow wax lesions, blood fat being deposited in the central macula. And this they cause, because there's leakage, it causes the retina to become swollen. So this is an abnormal image with someone with high hyperglycemia. The complications resulting in blockage of normal blood vessels causing abnormal blood vessels, because they're abnormal, they can bleed. And when they bleed, they cause hemorrhaging of the back of the eye. So this can either be vitreous, preretinal hemorrhage, and that hemorrhage can lead to, unfortunately, to blindness. And this is a stage where we try to avoid patient to get to. So the quality of conversations that Razia has already alluded to around education, patient support, which should help to avoid such complications. When we see patients like this in screening, the importance of attending retinal screening program, these are a group of patients that would want to see in the eye department within 2 weeks for intervention such as laser treatment. Leakage as well, there are practicalities with the leakage. When there's swelling at the back of the eye, it causes the retina to be swollen, then the edema with time can cause a loss of central vision. And what we tend to do for this group of patients, we do some diagnostics. Some of the diagnostic tests that we do are non-invasive, some are invasive, in order to evaluate a treatment management plan. On this diagram here, it shows some form of advanced diabetic eye disease Again, we tend to see now blood at the back of the eye. So blood sort of associated with end stage or structural damage to the back of the eye. And in some cases also there could be formation of new vessels in the iris. It could also cause some what we describe as proliferation, late stage proliferative diabetic retinopathy with some form of fibrosis. So again, all these clinical scenarios are avoidable with a good glycemic control. So I must say at this stage now, the screening program in the UK is set such a good legacy in terms of blind registration for people with diabetes. So the cause of permanent visual impairment and blindness among patients with diabetes or living with diabetes, I would like not to avoid calling them patients, but people living with diabetes, is significantly reduced since the introduction of the National Service Framework leading to the establishment of retinal screening in 2003. So therefore, routine screening does help. Why does it help? It helps with identification of sight-threatening conditions early and ensure that there's adequate or appropriate management plan. So this would prevent the development of sight-threatening disease. So again, it's important for those people living with diabetes to ensure that they see their local screening program. So how does it work in real life screening? Well, again, going back again to the National Service Framework, there's loads and loads of supporting data because the UK screening program, I think it's one of those programs as a public health intervention, has been widely acknowledged globally in terms of its effectiveness. So GP identify patients, people with diabetics above the age of 12, and provide details to the screening program. So there is the diabetic register, and the screening program automatically get a referral, and the person living with diabetes, they get an invitation to attend the screening program. When they attend the screening program, this is what happens. They get to see the receptionist, and they get to be called by the screeners. And the role of the screeners is to check the vision, take the history, put some drops in order to dilate the pupil, and then they take some photographs, and they also check the vision. And those images, as you can see, is to try to understand what's happening at the central part of the retina, the macula, and also at the optic nerve. So the images that we try to capture in screening are two sets of images: central involving images which are captured the macula, and then also the peripheral retina. And we go to the second eye and do the same thing. So the images that I've just highlighted on the screen shows no evidence of diabetic eye-related changes. So anyone, again, living with diabetes, it's important to ensure that you go for screening. Some screening programs are now advanced because they now have a medical equipment or some form of a diagnostic test advantage that can also be used to detect whether there's any leakage behind the back of the eye or not. When you come to see us at Moorfields in the eye department, what happens? History taking, we do lots of investigations, but it's also important to listen to your own story as the person living with diabetes. I see this as a partnership, as a dialogue that is established between us as clinicians and the person living with diabetes. Why I say that, if you articulate your history so well, you will tell us actually the diagnosis by just articulating your history. You can share the important things around driving, whether you're planning to have pregnancy, whether you're planning to go somewhere sunny during winter. All those things that you tell us will help us to evaluate treatment management plan. Some of the investigations we do scans. Scans is just a way, OCT, optical coherence tomography, to detect fluid at the back of the eye. But also we do another one called fluorescein angiograph, just to understand if there's any problem with circulation, oxygen supply, ischemia activities, or lack of good supply of oxygen. And when we look at your images, they tell us the extent of the damage, whether there's any formation of abnormal blood vessels, such as the image on the right-hand side, or if there's any peripheral, there's any problem with supply of oxygen behind the back of the eye. So the treatment options we currently offer ranges from laser, steroids, and anti-VEGF injections. So anti-VEGF or intravitreal injections, these are injections which has been around for some time because of good clinical research studies. Anti-VEGF, VEGF is a molecule that we have known as vascular endothelium growth factor. This molecule is known to cause formation of abnormal blood vessels. So anti-VEGF, it stops formation of abnormal blood vessels. So these injections, they're said to be quite effective in literature, but also from a real world experience, we see quite a number of patients being able to go back to driving, quality of adjusted life years improving. So injections can be administered under a sterile environment, given by nurses here in the UK and some elsewhere in the world, and it's quite safe. We take good care of the infection, also some of the practical guidance before you get consented. We give you the opportunity whether you want to achieve good lifestyle or some form of systemic control before we can load you on a course of injections. On the day of the injection, check the vision, you discuss with the physician, and you get your injection administered under a sterile environment. So the drug itself, when it's injected, it goes into the vitreous cavity, and then that's when it begins to work out. So it's quite clinically effective. Acceptability between patients is significantly improved. Then lastly, laser treatment for formation of abnormal blood vessels. So laser does help to destroy those abnormal blood vessels to ensure there is good oxygen supply. So good laser coverage on this image for someone with that laser energy treatment. So control is important. Why? This diagram just shows someone who has managed to achieve good glycemic control without any injection interventions or laser treatment intervention. So this is someone who came to my practice, history of diabetic leakage, both eyes, diabetic macular edema, as you can see on those scans, a driver, cab driver. We encourage them to exercise good control, give them some time to do whatever they needed to do, supported them, got seen by our diabetes specialists, and this is what they achieved. They go back to driving and the retina is drying up. So those were the practical things that I just wanted to discuss, and it's my aim to ensure that we close this meeting on time. So I'll stop sharing and try to bring all the panelists for the question and answer session. Thank you for your attention.
Thanks, Adam. That was very interesting. And it's so important to raise that, if you do get your appointment letters, eye screening appointments, it's so important to attend. And even with your appointments to get your diabetes checked, if it's in a language or jargon, you haven't understood it, please do ask your profession, please do ask the rest of the team if you can speak to somebody else, or maybe perhaps there might be someone who can give you the information in a language that is preferred. Don't be afraid, don't be shy, please ask if you haven't understood. It's so important that you get and deserve the care that you're entitled to. So it's now time for Q&A. I have had a couple of questions messaged in. Pravat, while you check the chat, and if anyone does have a question that they want to raise their hand, whilst you get ready for that, I'll go to one of the questions that have been messaged in. And I think, Tony, you alluded to this. The question is, can I give blood if I'm diabetic? Does it depend on if you're type 1, type 2?
It doesn't matter. They're able to screen, and of course I have the sickle cell trait, which doesn't cause me any harm at all. Go to the blood clinic. They will be able to do all the various tests and decide whether you are fit enough to give blood, or I'm afraid, no, you can't. But we need to, as African Caribbean and Asian people, make more effort to go out there to give blood. So I've been giving blood for God knows how long, and it's never impacted. They take a pint each time, and then they give me drinks, and you put the blood back in no time. So don't make having, whether sickle cell trait or diabetes or anything else, stop you from going and checking out. I can't tell you for sure. They'll take each individual on a personal basis, look at your medical history and determine.
Yeah, thank you, Tony. Pravat, do you have anything in the chat?
We haven't got any questions in the chat, but there's an interesting comment actually from Tony, who is commenting that, bear with me, I've gone and lost it now.
Well, like I just said, Robert, it's to do with having that needle injecting me into the eye.
Sure,
the thought of it, isn't it painful, or do you put you on the local anesthetic first?
Yeah, so I'll answer that for you, Tony. So the injections, how they're given, right? We give what we call topical anesthetics, and these are drops that are aimed to numb the surface of the eye, and they seemingly work so well, such that the process is almost like pain-free. And we also, just before we can apply the treatment, we just try to just sort of test whether the drops have worked or not. Yeah, so
it's like going to the dentist. Yes.
Yes.
Okay, that's fine. Because I don't like needles.
Anyone want to unmute and ask a question?
If there's no questions, Mapani, can I just mention something, please, that might help people? And that is, we have a website called No Diabetes. So it's KNOW Diabetes in Northwest London, and it's a fantastic website. It's got a lot of really useful information, and for people who speak different languages, it can translate all the pages into 99 different languages. And for people who might not be able to read, it also reads out the pages, so you can actually, it speaks out the information as well, so it can be really, really useful. So I just wanted to mention that.
Yeah, that is. And even with regards to the book that you mentioned, when we send out the link to the recording of the workshop to the participants, we'll make sure that we send the information and the links out to the resources that have been mentioned. So if you haven't got a pen or paper or have means to take down any notes, don't worry, we will send information out. Before I go to the other question that was messaged, I think I heard someone that wanted to come in. Can I just check?
Yes. My name is Pushpa, and I just wanted to ask, we are vegetarians, so if you don't have rice, if you don't have chapatis, which we don't have every day, we have chapatis perhaps once in 10 days, but we eat rice not very many times, perhaps 2 to 3 times a week maximum, and pasta also. But as I mentioned this earlier in the program a couple of weeks ago, the last program that we had, my husband had a COVID, and we went to the heart hospital. It's damaged his heart, his lungs, and his kidneys, and he's diabetic since he was 50, 75 now. His cardiologist said that you cook pasta and keep it in the fridge and have it next day, so that does not convert into carb. So we've been eating quite a bit of pasta now. So if we don't have that, what do we eat?
I mean, I guess what I would say to that is, it's not that you can't eat. You can eat like any carbs you want. It's really about portion sizes and not eating too much of it, really. Yeah, so I think you should still be able to enjoy food and enjoy the things that you like, but it's about just being, it's about being healthier, and it's about really watching the portion sizes. And in terms of that, keeping the pasta in the fridge, there is something about that if you don't have it immediately and you keep it in the fridge and it's cold, it might not have as much of an effect on like the blood glucose levels. But again, that will depend on the portion size as well. I'm not sure how much difference it makes or anything, but I would just strongly suggest just to look at the portion sizes rather than not eating anything altogether.
And I heard somebody said
that.
Sorry.
Could I just add to that, Pushpa? The portion of rice you eat must fit into the palm of your hand.
Yes.
Now, some people struggle with that. I used to love 6, 7, 8, 9 tablespoons of rice and peas. Come on, I grew up in Jamaica. Now I know the portion of rice you eat, and this is a cooked rice, because some people are laughing me saying in my sessions, are you talking the uncooked rice? This is a cooked rice. And the 3 rices you must go for, and this is on the Diabetes UK website where they have a lot of recipes. You must try to aim for brown rice, wild rice, and I have to spell that out because some people think I say white, W-I-L-D, brown rice, wild rice, or basmati rice. That's all on the website. Basmati rice, whether brown or white, those are the 3 rices you should be aiming to eat. No other types, just those 3 is what everybody should be aiming to eat in the grand scheme of things.
Thank you. Is it? I also heard somebody said that instead of having one big meal, you eat every 2 hours. Is it true? Little portions. No.
Some people go for 5 smaller portions, 5 meals a day, but others tend to go for whether 3 meals a day. And so each has to work out with your dietitian or your healthcare professional what's best for you. So we can't sit here and tell you, oh yes, have 5 portions, or have 3, or do intermittent fasting, or so on. You have to go and see your dietitian and work out your height and your weight and so on, and what calories are you going to take in, and what portions of fats and so on. It's sort of general advice we're giving now, but you need to, with your healthcare professional, work out a diet plan for yourself. That's my advice.
Thank you very much. Thank you.
Thanks, Pushpa. The other question that came in was, I've been diabetic for nearly 10 years. I am on metformin, I'm type 2. Is there any chance for me to go into remission with diet and physical activity?
And for me, that would be that you'd have to then discuss that with your clinician, your dietitian, your doctor, and so on. They know this person's medical history. We don't know. So we can't sit here. I always say to people who say, well, Tony, based on you, I'm going to come off medication straight. I say, oh, no, you're not. You come off medication gradually, slowly, under supervision, under medical supervision. That's why I have a insurance badge which says, oh, well, Tony Kelly said I should give up medication. I've never told anybody to give up medication. So it has to be discussed with your healthcare team.
Yeah. I mean, what I would say is the longer that people have diabetes, then they may not be as successful in achieving remission. And with our program, the Rewind program, if people have had diabetes for more than 12 years, they're not at the moment eligible to join the program. So like Tony says, it's really important to discuss with your diabetes team and then take it from there.
Thank you. Anybody else want to ask a question or comment?
Subhash, I would like to say something.
Hi.
Yeah. First of all, absolutely brilliant presentation from all the 3 speakers. And, Adam, I really wanted to thank you for your the really beautiful slides on retinopathy, because since last about 4 months or so, as there's a lot of release in the people meeting up and all, I have had the occasion of going and giving talks at 5 different places. And you know that I talk about eye health care. And I think I need to add diabetic retinopathy in it. And I would really require your help in putting up those beautiful slides so that at least when I go out into the community, when they invite me to give a talk, I think we'll be able to make a difference. And all 3 of you, and especially listening to Tony, was absolutely amazing. The passion behind him is absolutely brilliant. And what he said is, Adam and Bhavini, you are both aware that since last about 9 years, I have been actually going out into the community and speaking at various venues. I mean, Gurudwara has been absolutely brilliant. Nisden Temple. I mean, the last meeting, there were about 500 people in the audience. And when you speak in their own language and actually are communicative enough to make them understand the value of having regular eye checkup, and that really works. And then what they feel is a reassurance that, yes, there are people out here who will be able to help us and guide you into the proper way. So thank you very much for all three of you. And thanks, Bhavini. It's a beautiful program.
Thank
So
you.
could I
Thank you
ask
so
a
much.
question?
Yes.
Hello, it's Carol.
Hello.
Hi, Carol.
Oh, it's,
I would like to put a question to Tony.
Sure, go ahead.
Good afternoon, Tony. As someone from Jamaican heritage, I find that I'm being checked once a year, at least for diabetes. My doctor says it's food that I eat, the West Indian food, very high in cholesterol, and it can have some significance to do with diabetes. Do you think that's the case?
Yes. Remember we said earlier about the DNA amongst Black people on the whole, African Caribbean nation, the DNA, the genetics, the metabolism. So that's point one. Yes, diet has a lot to play with it. So for instance, nothing's been mentioned so far, but believe it or not, although there's something called sweet potato, it has a low glycemic index. I would rather you eat more sweet potato than eat yam and dasheen and cassava and cocoa. But our diet, so when seriously, and when I was growing up, and my grandmother and my aunt would give me susumba and gully beans and lettuce and salad and those things and greens. I'd say that's rabbit food, that's for guinea pigs. That's what I eat now. I've cut down on the carbohydrates, a small portion of yam, small portion of cassava or what have you. And when we go to Jamaica, and if you do go, for God's sake, don't eat the festivals out there. Dumpling or fried dumpling or Johnny cake, what you putting sugar in that and calling it festival for? That's just a recipe for disaster. So yes, our diet is part of it, but also make sure you have a lot of vegetables on your plate. Lots of vegetables, please.
What I find, Tony, and thank you very much for participating in today's discussion. As someone with visually impaired, like I said, I'm from Jamaican hereditariness. I've learned to try and cut down on the food, the cooked food, and the sugar. So we use a lot of salt, a lot of sugar. I don't know what that's about, and I'm learning in my early prime now of life to try and cut down on such matters. And I think that when I had my last diabetes check, everything was okay. And I get my feet. I will be this Thursday. I get my feet examined for the diabetes. But I'm taking on board what you're saying, because as I think as a culture, we're very. You did say it in your presentation. We're very. I would use the word ignorant or naive to really be the more, not your gen or my gen, but the beyond before. Don't want to discuss such matters. It's just not discussed.
They do with me, because when I go to my events and I say, you're here to listen to what I have to say, it's not education. I don't like the word education, because that means that you're sending people back to school and class. It's awareness raising. And for 9.5 years, I've been doing this. And people said to me, Tony, I've learned from you more in 1.5 hours than having had my diabetic nurse and doctor for the last 15, 16 years. You keep it real, you keep it live. It's expert, patient, expert experience, patient, expert, your lived reality. You can't beat that.
I think, Tony, just very quickly, I think, Tony, I like to say, as from a Jamaican descendant, is that a lot of the practitioners who people see from Afro-Caribbean, they do not relate historically where these people traumatically are coming from and why they turn to these certain foods.
So lack of cultural competence, and you need to have a cultural competence about you to deal with the African, Caribbean, and Asian people. You need to know about Karela, you need to know about Susumba, you need to know about ladies' fingers, all these sorts of things. If you don't know, how are you going to tell people about their diet?
To these foods, Tony, I think we, as historically, we turn to these foods for a sense of emotional comfort, and we don't see the aftermath, what it does to our well-being. So thank you very much.
Thanks, Carol. Can I check if there's anybody else who wants to ask a question?
My name is Ceflin Brooks. I just want to thank you all for putting on this program today, because I'm going to uni, and one of my topics I chose, it was diabetic. I didn't know where to start from. I have to go and do research. But I know when I was little growing up, my dad died from it. When my mom said, oh, as Tony said, the Jamaican people doesn't talk about diabetes. They said sugar, a touch of sugar. So my mom used to say, oh, your dad have a touch of sugar, but I was quite young. So it's when I grew up now, when I came to this country and my two uncles died from it now, then I realized they are talking about diabetic. So one day I was feeling so ill. I didn't know what happened to me. I was so weak and feeble. And then when I went to the doctor, they took a blood test from me, and the next minute I know they called me urgently to come in the surgery, and I was really worried. So when I went there, they said to me, I'm on the borderline. I said, borderline of what? Diabetic. And I said, oh my God. But for me, I didn't like to eat food. I like to eat like Snickers, chocolate, Lucozade. That nearly killed me one day at the bus stop. The whole world was black. So anyway, I went, and the doctor said not to eat those anymore, and I was fine, because I don't like to eat food. I like a lot of salad, vegetable, and drink a lot of fresh water. I like to eat a lot of fruits. Mango is my favorite. I will sit down and eat like 12 mangoes or more. So I'm not realizing that it wasn't good for me. But anyway, I went there, and they put me on a diet, and then it's like every year they monitored me, and then I realized that those things never good for me. And they said a portion, your handful in your hand, a portion of everything. So I went on that one now, and I don't know what happened. One time I was feeling stressed out 2 years ago, and I went back on the same food, and the same thing happened again. And I have to attend the clinic in Elephant and Castle. And then due this the COVID last year, they done 3 months of recap with all of us on Zoom. So I went back on the diet that they put me on, and I'm fine now. I realized that what I'm eating is not good. So I just cut away from everything, because when you get in age, from you past 40, you have to be careful what you eat and take care of your body more. So that's what I'm doing now. So I just thank you so much for putting on this program, and it educated me more, as Tony said, talk about education and those things, but it put more understanding for me right now, what to eat and what not to eat, and what portion to eat. So thank you all for putting on this program. I very appreciate it, and I get a lot from it today to put in my essay.
Thank you, and thanks for your comment.
You're welcome.
Thank you. I probably have time for one more question. Does anyone have any, or Pravit, if there's anything in the chat?
Can you hear me?
Yes.
Shirley.
Shirley, hi Shirley, go ahead.
Is it possible that someone could give us a brief description on what all the medication does? I'm on sitagliptin and cannot take metformin.
Razia, Adam, who would be best placed to answer that?
Yeah.
Razia, please.
Yes, sure. So yeah, metformin is a really good drug, and it's one of the first drugs that we choose when people need diabetes medication. If they are overweight, because the metformin helps the body to use up the glucose a lot more, and it helps to reduce the insulin resistance that we spoke about earlier. The thing with metformin, some people aren't able to take it. It's important with metformin to take it with or after food, because if you take it before food, you're more likely to have gastrointestinal, so tummy sort of side effects, I'm not sure if that's what you experienced.
Was just sitting up in bed heaving at night all the time.
Okay. So because you didn't tolerate it, they've started sitagliptin. So the sitagliptin is a drug that acts on hormones in your gut that help to control the blood glucose levels. They don't cause hypos, like there are some drugs that can bring the blood glucose level down too low if people don't maybe if they miss meals or they're a lot more active than usual, things like that. So it's a drug that doesn't cause hypos. And yeah, it can help to nudge the blood glucose levels down a bit if they're just a little bit higher than, you know, you would like them to be. Does that help?
I've just also been put on the EMP, what do you call it?
Empagliflozin.
Yes.
Yeah. So that is a drug. Now it works very differently. What it does is it helps to reduce glucose by like through the kidneys. So like the excess glucose is passed through the kidneys into the urine. So it helps to control the glucose that way, you know. Yeah, I mean, the medical term for these drugs are SGLT2 inhibitors. So they inhibit the reabsorption of glucose from the kidneys, you know, and it passes the glucose out into the urine. So that's how they work.
What's the glyso something? There's a further drug, isn't there, that a lot of diabetics take?
A glycoside?
That's right, yeah.
Yeah, so the glycoside is a drug that helps the pancreas to produce more insulin. So that's how it helps to improve the blood glucose levels. Yeah, so it stimulates the pancreas to produce more insulin. So like, yeah, a lot of the drugs, they work in different ways to help control the blood glucose levels. And some of them we find have additional benefits. You know, some of them we find actually have had cardiovascular benefits. And, you know, so, you know, again, when we are looking at starting a drug, if somebody needs medication for their diabetes, we would need to look at their individual circumstances and their individual medical history and things before deciding what would be suitable or best suitable for them.
Can I just have one final point here? A lot's been mentioned about drugs. What your listeners and viewers need to understand as well, there's something called social prescribing. It's the buzzword now. And there are a lot of GPs out there who have in their budget money for the person to go to a gym, to go to dance classes, to go to Zumba, to go to swimming classes, out of not the patient's money, out of their own GP's budget, so that they can lose weight, they can trim up and tone up and so on, come back and see them in 3 months' time. So alongside the drugs, there is social prescribing. We need to make sure we're getting that message out there so patients are aware they don't necessarily have to go immediately down the drug route. Ask your GP to look at a course of this or that or the physical activity, please.
Thank you.
Yeah, I think that's a very important note to end on. And I'm afraid we're going to have to leave it there. We have run over slightly, and I'm sorry if anyone did have any further questions. Please, you know, get in touch with your diabetic team. They will be the best place to ask your questions and the best type of support they can offer you. We will share this recording with you and put links to the resources that have been mentioned today. So I just want to end by saying a massive thank you to both Adam and Razia for joining us as professionals, and Tony for that fabulous presentation. It was really empowering and your passion and energy just oozes through, and just wanted to say thank you for joining all three of you today. And of course, our participants that have logged on today, I hope you found it useful, and we will share the recording with you in due course. Thank you and enjoy the rest of your Sunday from all of us here at BAME Vision.